A team. And so it's good to be able to be with you. I'm Dominic, and I'm a practicing physician, data scientist, and AI ethicist. So kind of in between patients, I do AI research and teaching in that. And as you probably have seen in your respective worlds, there's always that question, what could we be doing better? And particularly in my world at the bedside, over and over again, we see where are we failing our patients? We're losing too many of them. And so the question's increasingly begged, therefore, with AI, is there a way we can be doing this better? Is there a way our systems can come alive, can think, can adapt, can respond, can deliver the kinds of standard, safety, quality, affordable, equitable care our patients want when they come into our doors? And so these are my disclosures, and these are my cute kids. They like to think big. They love the stars. And so I'm reminded in these kind of sessions, because it's a data scientist conference, right? So let's do some poetry. So one of their favorites is one by Whitman, when he says, "When I heard the learned astronomer, when the proofs, the figures were ranged in columns before me, when I was shown the charts and the diagrams to add and divide and measure them, when I was sitting, heard the astronomer when he lectured with much applause in the lecture room, how soon unaccountable I became, tired and sick, till rising and gliding out, I wandered off by myself in the mystical, moist night air, and from time to time looked up in perfect silence at the stars." Now, I don't recommend wandering out into the Vegas deserts at night. You may not be able to see the stars, but I think we've got the idea about how can we try to recover this big and bold and hopefully a better vision of how we can build systems that patients need and expect. And so I'd like to be able to pitch to you and learn from you about how maybe we may be able to take this trustworthy AI embedded in healthcare systems. Can we leverage that to automate and transform clinical and operational decision-making in this emerging model of what the future healthcare system can and should look like in this digitized, globalized world we're operating in? So I'd like to try to do so with the possible emblematic or illustrative case of Cardio-Oncology, trying to take this AI-enabled end-to-end analytics solution that takes three main pillars of this methodology I'm pitching of causal inference stats, the cost-effectiveness component, and the computational, ethical, and policy analysis. One that tries to take effective and equitable cardio-oncology care that also tries to take together human dignity and cultural diversity, trying to bring it together with ethical AI, and ultimately trying to integrate. How do you bring together value and values? How do you bring together precision medicine and public health? How do you bring together the present and the future of what systems can do? And so to treat effectively, I have to diagnose correctly. And so I have to ask the painful questions that I believe some of the speakers have been hitting upon and what's intuitive, I think, to much of us. So is healthcare not living up to what it should be? Is it unaffordable, unequal, and effective? And so some of the representative and emblematic stats, as you're probably well familiar with, goes back to almost 1 in 2, even insured patients in the country believe healthcare is not affordable, that 1 in 4 of our patients are skipping meds accordingly, and it's the top 3 worry for people financially. Is it also unequal? We're seeing 54% and almost 70% respectively for African Americans and Hispanics facing greater cost barriers to systems than Caucasians. 70% of our world's healthcare inequities centered in the developing world, with almost 100 million pushing to extreme poverty from it. And also, is it not even doing its job? Are we still facing this reality where up to the 3rd leading cause of death clinically in the world is still medical error, that almost 1 in 2 of us going into a hospital are going to experience some kind of medical error, with 80% of it being preventable? I don't know how many of you would walk into an Apple store to get a phone and you have to worry about the ceiling falling on top of you. And we see that we understandably make a lot of patients dissatisfied, with almost 70% not happy with the unaffordability and the inaccessibility of systems, and even the quality for it. But our systems operate also in larger social challenges that, as you know, systems bridge complex realities, both politically and economically. We think regulations, we think supply chains, we see the recent pandemic, but also in complex cultural divisions. As we try to take the disparities and diversity seriously, we're seeing increasingly systems are having to bridge large areas, even cross-nationally. And so we see this kind of divisions politically, the West and the East. We see it with the North and the South. We see it with the digitally connected and those who are not. Also polarized. Some of the numbers from almost a decade ago that are almost certainly worse now. over 90% of our major political parties in the US alone are saying we don't know if we trust those people on the other side because they're too far compared to the center. 1 in 3 even saying that the other side is, quote, a threat to the nation's well-being. How do you have compromise in this kind of situation? If AI is meant to be a tool showing us how to help fix healthcare systems, we have to first answer the why as well, right? If we're trying to bring together diverse peoples to make this solution work and make it sustainable. And ideological, replacing and amplifying a lot of these divisions as well. We're seeing a lot of the geopolitical stressors and challenges that complicate these kinds of interconnected, globalized networks that drive the on-the-ground, at-bedside reality we face. And so what I'd like to pitch is this concept of, can we bring science and ethics back together? Can we bring those common tools back with a common sense approach that allows us to solve common problems for our patients? So I've tried to apply this work from a couple years back in the context of global bioethics for a lot of our urgent healthcare challenges, and also to the right, the book that came out last month, trying to look at that in the context of multicultural metaphysics. The Elsevier book coming out at the end of the year is meant to attack that problem from a healthcare both system design and also management standpoint. Ultimately, can you bring data and dignity back together? Can you bring effectiveness and equity? Can you bring trust in AI? And so the ACE methodology I'm proposing is one in which I've tried to conceptualize and to operationalize this of an AI-driven computational ethical and policy analysis that tries to digitize embedding human dignity in our digital healthcare ecosystems. One that tries to take this kind of end-to-end, not just technically and organizationally, but even epistemically, because of the challenges we face in bringing diverse groups together, and one that allows us to be able to bring the traditional stats that clinical audiences were more familiar, comfortable, and confident in, the propensity score stuff when we can't do the big RCTs, and also how can we try to integrate that with a lot of the emerging ML and also deep learning solutions, allowing us to scale and adapt these kind of analytic approaches that take seriously as well the dollar sign. If we can't afford to do a treatment, should we even try? And also, ultimately, the ethical and the policy. At the end of the day, we've got to make a decision at an organizational level. What do we do and how should we do it for the populations coming into our door? And so ultimately, it's trying to be able to take the modern ethics, anchor it again into a classical metaphysics that tries to take rights and making it usable again, to try to bridge a lot of these impasses in a way that is able to take seriously the diversity of the people coming in through our doors, one that is able to integrate instead of divide a lot of these systems. And so how do you then take a step further and digitize and mathematically translate this into healthcare systems so they can actually get up and run, not just developing case uses, but a new way for systems to not only augment, but also to some degree even automate system management. So for those who are mathematically inclined, the Fourier convergence series, because of course you want to see this after lunch, looking at healthcare big data with the precision medicine, PR Med, and also the public health, raising it to the power of AI value-based healthcare. That itself is that product of the ACE methodology we just talked about with practical AI, and also that value equation, quality divided by cost. Ultimately trying to see the more complex reality in our hospitals, really seeing the digital side, the dimension of it as well, trying to ultimately allow us to leverage the diverse stakeholders in the digital healthcare ecosystem, private, public, academic, and social, to try to be able to get after the IT architecture underlying much of our world, where we see that kind of three-layer, that distributed cloud system, the fog intermediary layer, and also the digital edge portion with the user end devices that take seriously this is how our patients are increasingly operating, and how can systems plug into this more rich reality to deliver those kind of outcomes patients need. And so ultimately it's trying to get us to actual solutions. So this is a paper my team published just about a couple of weeks back in the PubMed Journal of Medicina, asking this kind of methodology question in a real-world case example of cardiac arrest. Clinically, you may already be well familiar with that. Essentially, in an arrest, our patient's hearts stop pumping effectively. The electrical signals that propagate to the rest of the heart saying, hey, pump now, doesn't work as well. And that quickly, understandably, leads to death. You're seeing about 2 million brain cells lost every minute. That blood cessation goes on, and so we need to restart that heart as soon as possible. Now, this is particularly an equity challenge for systems, and one in which we've underperformed for almost 3 decades. We barely moved the needle in terms of improving arrest outcomes, particularly for the lower income and racial minority communities, because it makes sense, right? Much of what arrests are driven by is chronic diseases, think hypertension, diabetes, et cetera, that gets to a point where the heart can't take it anymore, it gives up. Nothing hurts worse than to have one of your patients come in and you ask about their mom and they just tell you, well, mom just died. What happened? She just dropped dead at the age of 50. We're seeing patients as 40, even earlier. So the question becomes, if you can't afford to take your medicines regularly, you can't even afford to go into the doctor regularly and figure out that you actually have diabetes, how can we do better? And so this methodology, ACE, we applied it in the context of cardiac arrest, being able to tease out some of the implications in a 101 million plus patient data set is a nationally representative data set from the Department of Health and Human Services in the country, looking at about 1 in 5 hospital admissions in the US. And what we found is, not surprisingly, these disparities were also prevalent not only in cancer populations, but were worse in the cancer population. That understandably, this is often a more clinically complex patient population, so we sometimes are less ready to be able to apply some of the standard practices and arrest protocols for this higher risk group. Yet we see, if you look in the far left figure, I'm sorry, I don't have a little red dot here, the big bars, the light blue bars, that's a lot of mortality for cancer patients. Look at the smallest bars, though, on the far left side. That's what happens when we do those cardiac catheterizations for them. It's a bigger clinical improvement than for patients without cancer. Patients with cancer do better when we do these catheterizations early, indicating that even adjusting for the clinical confounders, these disparities hurt. If we fix them, we can get that disproportionate benefit from it for these patient populations. We took it a step further and asked the question, can you take an approach to be able to early risk stratify patients coming in with just the ICD-10 codes, that early admission data allowing us to quickly try to personalize the care for the patients coming in and improve those outcomes ultimately? We found that CACOS score that we developed that has that stepwise mortality increase as we go up in the score. And then we were able to replicate and translate these findings using a deep layer algorithm, using a 5-layer neural network approach, allowing us importantly not just to say, yes, great, the model works now, but how can you embed it in an EHR that's able to adapt with time and scale to the system's needs? And so this kind of cardio-oncology case use for this ACE methodology, we've replicated a little over a couple dozen times in a few of the recent studies in the last 3 years, looking at similar case examples outside of the arrest world. And so ultimately, it's trying to be able to get to those results for our patients. How can we take that human intelligence, both scientifically and ethically, the math and the beauty side of what we know, embedding it via AI into those kinds of value-based healthcare systems that allows us to be able to do patient care and system management better, allowing us to take precision medicine and public health, bring it to bear for the patients coming in for us. How can you take those ecosystems of value chains, being able to better allocate the resources as you're seeing who's coming in and what they need, and ultimately being able to take seriously that digital architecture dimension behind all of it. Ultimately, if we can develop better effective and equitable outcomes, does it require us to take more seriously the diversity of our patients coming in and ultimately the dignity of the person walking through our door? So circling back through our objectives, it gets me back to a point when all this kind of began. I think like a lot of you asking these kind of bigger questions, these kind of challenging solutions that may be able to get after it, and all this kind of technical how, for me, started with the why when I was a kid, and I remember not too far from my home seeing the unfortunate tragedy of Columbia in '03. And I remember these words that still kind of sticks with me with much of where the AI research I do still comes in. You may be familiar with this, where it was noted this cause of exploration and discovery is not an option we choose. It's a desire written in the human heart. We find the best among us. We send them forth into unmapped darkness and pray they will return. They go in peace for all mankind, and all mankind is in their dead. This is my oldest, Lucy, looking up at the stars, and this is me looking at you saying, we desperately need you. You're among our best and brightest. We need your skills, your expertise, your interest, so that way we can do better for our patients. As ultimately, without healthcare, how can our societies continue? And without common solutions, how can we have a common home? And so here's a little bit of the meat of it, and I'm happy to be able to, good. I was trying to save a few moments for questions, critiques, pies, fruits, angry gaffes. I think we have about 5 minutes. Okay, great. Ooh, you'll make this easy. Come on. If you don't mind, therefore, if I can pitch before hopping off the stage to give a few moments for the next presenter, as I think I have a few last seconds left. Is there, if you don't mind, any particular areas that you see in your systems, in your neck of the woods, in your respective sectors, where you feel like gives you a lot of hope, for these kind of challenges? Is there anything, though I'm coming at it from a cardio-oncology standpoint, is there anything that y'all see as things that tell you this may be a way forward?
Like potential benefit of helping minority
Mm-hmm.
communities.
Thank you. We have a great point in terms of trying to help the minority communities. This is one of the things that we've tried with some of our affiliated institutions, being able to leverage, as you may already be familiar with, that participatory research model, where instead of going to communities and saying, hey, this is what we're going to do, we're going to collect data for you and tell you what you need to do differently, it's trying to listen to patients first and listen to the communities and saying, what's important to you? What's important to me as a researcher or a clinician may not be the same thing, and trying to triage and focus those resources accordingly. So thank you for that point. Mm-hmm.
So I guess not only from a medical standpoint, is
Mm-hmm.
predictive power going to be powerful in the future for predicting presence of disease? I'm hoping that
Mm-hmm.
the AI matures enough to also let the doctors know where the weaknesses of the system are.
Right.
You know, if for instance, you know, something is happening within the system, you notice, you know, different values going up, but maybe a creatinine hasn't been checked recently. You notice that there might be some racial discrepancies, some financial discrepancies that the doctor would know. Maybe in this case, a creatinine should be checked in order for that disease to be caught early. So not only the presence of disease would be caught, but also the lack of care would also be caught for analytics.
Great point. In terms of if I hear you correctly, a lot of the process intermediary points getting us to those ultimate outcomes. There's two really interesting, if you don't mind me dovetailing that, two interesting advancements at the University of Leeds in the UK in terms of their AI command center, similar to mission control systems where we think in nuclear power plants or high-risk reliability organizations. How can you try to have an information structure that allows you in real time to be able to understand where your weak points? And one of the associated UK interventions as well, in parallel with that, is the automated medical algorithm AI approach, being able to understand in real time how can you do AI on the AI, helping us understand where are we falling short in a way that it can allow us to be able to push those kinds of intermediary process metrics that allow clinicians to say, I may have missed this for this particular patient population. So great points. My hope is with the mission control and with that kind of medical algorithm approach in terms of the auditing that allows that better synchronization of resources and allowing us as well to have also the strategic design, aside from the clinical component, also at a system level. Are we building enough clinics in low-income communities? Do we have enough telehealth offerings to rural populations? How can we not just look at one patient at a time, but the entire population? That's where the population health component comes in as a complement to the precision medicine. Great point. I think I've got just a few more seconds. Any other ideas? What are we missing? All right, and so, yes, sir. You're referencing the regulatory component? Great question. And so in terms of the regulatory component, are you referring specifically to what we're talking about in general or to what I'm proposing in terms of that ACE methodology in the context of cardio-oncology? More broadly, yes, sir. And so I have a whole chapter in my book with Elsevier coming out this winter that looks just at that question. We've got some really fantastic pharmaceutical representatives here, a lot of great medical device corporations, a lot of good public, private, academic people here. And so what it looks like from our standpoints in terms of trying to develop and deploy these kind of AI approaches, we very much are concerned that you have that. I think the great NYU presenter earlier hit upon this earlier this morning about those overlapping complexity of regulatory bodies. There's a great study that was just put out by the British Standards Committee over in the UK, again, a couple of months back, asking at a global perspective this hop, skip, and jump patchwork of regulatory frameworks, both from a professional body standpoint, also from a government standpoint, and from a payer standpoint, and even internally to corporations designing a lot of these algorithms and devices, about how you can streamline and standardize what are best practices in AI, what are the parameters where you fall too far out. It does look like there's hope in terms of what the FDA approach is trying to be able to actually incentivize a streamlined regulatory process to encourage this kind of innovation, trying to use that as a new template for how can you try to remove a lot of the barriers for that, the rapid rate upon which innovation is required, but keeping it within acceptable parameters that still maintain societal trust in the transparency of the process. There's a lot of good things, for instance, with blockchain that's looking at those kind of questions, and a lot of that as it relates to the community participatory research model. So great point. I hope to have better answers for you in the book. And I think I'm in my final 3 seconds. So thank you all. I look forward to learning from you on the back end.